a peripheral nerve. So as you can see in this diagram, that first we see the longitudinal section, so in which we see the axis cylinder and the myelin sheath is present, and myelin sheath which surrounds the axis cylinder. Now as you can see that myelin sheath is absent at a regular intervals, so that is known as a nodes of Renvier. Whenever we see the conduction of impulses, so impulse will jump from one node of Renvier to the another node of Renvier. This kind of conduction is known as a saltatory conduction. And if you see the transverse section of a peripheral nerve, so as you can see that this portion, this much area is of the axis cylinder, and there are multiple concentric layers of the myelin sheath. And the Schwann cells, as you can see in the longitudinal section, so it actually appears like this when we see the transverse section. So this was all about the structure of a peripheral nerve. It is a heterogeneous group of immune mediated disorders, and it can be acute or subacute, symmetrical, predominantly a motor neuropathy, and in which more than one peripheral nerves are involved. The hallmark of the GBS is acute paralysis evolving over days or weeks with loss of tendon reflexes. Let us understand the beginning of the disease. So, as you can see in this diagram, there is onset of symptoms and the disease progression. But prior to onset of symptoms, about two-thirds of the patient, they give history of gastrointestinal infection or respiratory infection. There can be diarrhea if there is gastrointestinal infection, or fever and cough in the respiratory infection. So the most common organism behind this, that is the Campylobacter jejuni. Campylobacter jejuni is the most common organism. Other organisms may be present, that is the Epstein-Barr virus, or there can be Mycoplasma pneumoniae, where there is a bacteria causing the respiratory infection. Another reason behind the onset of symptoms, that is surgery. That is, after 4 to 5 weeks of surgery, patient may develop the symptoms of GBS. Next thing is the prolonged use of antidepressant drugs. Prolonged use of antidepressant drugs, which can give rise to the symptoms of GBS. And the last thing is, that is unknown reason, that we call it as a idiopathic. That is, the reason is not known behind the onset of symptoms. But do remember this thing, that 66% of the patient, they give a history of gastrointestinal infection or the respiratory infection, and the symptoms that I have mentioned in the most common bacteria, that is the Campylobacter jejuni. Let us understand the pathophysiology of the GBS. That, as we know that the Campylobacter jejuni bacteria, it causes the gastrointestinal infection. So what our body's immune system does, that our immune system, after a duration of about 1 to 4 weeks, our immune system makes antibodies. Those are the anti-gangliosides antibodies which are formed, and they are targeted towards the lipopolysaccharide which are present over the surface of the Campylobacter jejuni. Now what happens is, these antibodies, they are actually formed in order to remove the infection which is caused by the Campylobacter jejuni, and these antibodies will target over the lipopolysaccharide which is present over the infective pathogen or the infective organism. But what happens is, the gangliosides, these are the structures which are present over the myelin sheath throughout its course. So I can say that these gangliosides, those are present in the peripheral nerves and over the surface of the myelin. So what happens is, the antibodies which are formed by our immune system, they target lipopolysaccharide of the Campylobacter jejuni, that is good, but they are also targeted over the gangliosides present over the myelin sheath. So it causes the abnormality in the myelin sheath and the conduction of impulse becomes altered. So that was the pathophysiology of the GBS. Very simple to understand. Let us revise it. That our body's immune system, after a duration of about 1 to 4 weeks, formed antibodies which are antigangliosides, and they are targeted towards the lipopolysaccharide present over the surface of C. jejuni, but because of the ganglioside present over the myelin sheath throughout the course of a peripheral nerve, so those antigangliosides, they also act over the ganglioside and destroy them, and hence the conduction of the impulses, it becomes slow. That was all about the pathophysiology. Let us understand about the clinical features of the GBS. So as we have discussed that it is acute as well as symmetrical, more than one peripheral nerves are involved. So in this case, if I focus, that is first one, that is it is an acute disorder. Second thing is the motor paralysis, in which the proximal muscles are more affected than the distal one. So let me mark it over here. That suppose this is the hip joint, this is the knee joint, and here is the ankle. Similarly on the other side, that is hip, knee and ankle. So the proximal muscles, which is the hip musculature, knee musculature. So the knee joint is placed more distally than the hip joint. So the more marked motor paralysis, or I can say the lower motor type of the weakness, which is seen more over the proximal musculature, that is this much area, then the distal one. Distal one, that is the knee as well as the portion below the knee joint. And this is symmetrical. So the symmetrical one, proximal muscle weakness, so surrounding the hip muscles. So that is the proximal muscle weakness, which is seen more markedly. Second thing is it is symmetrical, as I have discussed. Sensory, that is the paresthesias. Maybe sometimes patient explain that I get the feeling that is the paresthesia like. Next thing is, after the involvement of the lower extremity, it travels up into the upper extremity. But the similar thing happens that upper extremity involvement, it is also a bilateral. Proximal muscle weakness is more than the distal muscle weakness. And the more important, that is the element type of weakness. So the reflexes, as I have discussed earlier, the reflexes, they are diminished, or there can be an areflexia. Other symptoms, that is the bifacial weakness. So let me write it over here, that there can be a bifacial weakness. Very rarely, but GBS, as it is a kind of the ascending paralysis. So ascending paralysis, it goes upwards. It's very rarely it involves the cranial nerves, and there is bifacial weakness is there. Let me write it over here, that it is bifacial. Sometimes the bulbar muscles, that here lies our bulbar muscles. Bulbar muscle weakness is also seen, and in the autonomic system, that is the heart rate fluctuation and the blood pressure alteration. So let me write it over here, that in this case we see the heart rate as well as the blood pressure abnormalities also. And one of the most important complication in case of the GBS, that is the involvement of the respiratory muscle, that is the diaphragm. So diaphragm, it is the main muscle for the inspiration. As we know that inspiration, it is an active process, and the expiration, it is a passive process. So whenever there is involvement of the diaphragm, it is an active muscle. So the patient's whole breathing pattern will be altered, because the major muscle which contributes to 80 to 90% in one breath. And remember, one breath is equal to inspiration plus expiration. And the inspiration in active, that is diaphragm involvement is there, so the whole breathing pattern is going to be altered. So these are the clinical features. That if you start from distal, that is the distal to proximal, that is the ascending paralysis, in which the proximal muscle weakness is more marked than the distal one. Then there can be the bifacial or the bulbar muscle weakness, which can be seen. Heart rate and the blood pressure irregularities are seen, and the most common complication and the most dangerous, that is the involvement of the diaphragm, which causes the major alteration in the breathing. So that was all the clinical features of the GBS. Now let us focus on some of the clinical variants of the GBS. So the first clinical variant, that when you are assessing a patient and you see a triad of ophthalmoplegia, areflexia and ataxia. So let me write it over here, that is the first variant of the GBS, and you see a triad of, that is ophthalmoplegia, areflexia and ataxia. So the triad of these three is known as a Miller-Fisher syndrome. That is Miller-Fisher syndrome. That is the first variant of GBS. Second variant of the GBS, that is the AIDP, that is acute inflammatory demyelinating polyneuropathy. So as we have seen that there is infection of the GIT as well as the damage to the myelin sheath is there. So the inflammatory process is also going on in the pathogenesis, as well as it damages the myelin sheath, that is the demyelinating and polyneuropathy. That is more than one peripheral nerves are infected, or I can say they are under the pathology, that is AIDP. So inflammatory demyelinating polyneuropathy. Inflammation is also there, myelin sheath is ruptured, so demyelinating is there, demyelination is there, and polyneuropathy, that is more than one peripheral nerves are affected. Third variant of the GBS, that is pharyngeal, cervical, brachial variant. So in this you see another triad of ptosis, that is drooping of eyelid. Second thing is pharyngeal muscle weakness, and the last one is that weakness spreads to neck and the upper limb, that is upper extremity. So you see a triad of ptosis, pharyngeal muscle weakness and the neck and the upper limb weakness, that is the pharyngeal, cervical, brachial variant. That is the third variant of the GBS. Now another two different and interesting variants, those are the acute motor axonal neuropathy. So in the AIDP we were using the term that is demyelination. Myelin sheath is only affected. Here we are using the term that is axonal. So here the antibodies which were against the Campylobacter jejuni, now they are going to affect over the axons, and typically the motor axon. That's why the name is acute motor axonal neuropathy. Next thing is acute motor and sensory axonal neuropathy, in which axons are also there, but the motor as well as the sensory, both type of axons, they are affected. So do write this short forms whenever the variants of the GBS is asked. Now comes the diagnosis of the GBS. Diagnosis, let me write it over here, that diagnosis of the GBS. So there are a few things that we need to remember. That first thing, is it progressive? Yes, in the case of GBS it is progressive. Second thing is symmetrical. Yes, in the case of GBS it is symmetrical weakness, and particularly more than one limb is involved, so it is symmetrical weakness. Third one, that is the progression which is less than 4 weeks. In the less than 4 weeks we see the progression of the symptoms. And the last one, that is hyporeflexia or the areflexia. Now these things, they are actually not enough. We need some investigation. So in the investigations, CSF analysis, CSF analysis in which during the first week of the symptoms, CSF may be normal, but after 1 week, CSF analysis shows there is protein level is increased. Protein level that is increased. Next thing is the nerve conduction velocity test. So nerve conduction velocity test in which we see the slowing of the conduction. Slowing of conduction. And the last one, that is in many patients there is increased amount of antigangliosides. Antigangliosides, antibodies. In some of the patients it is seen. So these are the three supportive things which helps in diagnosis of the GBS. I hope you like the way of presentation and this concept of the GBS. Do like, share and subscribe this channel. Don't forget to give your feedback in the comment section. Thanks for watching the video till end. Thank you so much. Keep sharing the videos.